current presentation is addressing the concept of adherence to medical treatments um, as pertains to the nursing education. Non-adherence is an important public health consideration and is affecting health outcomes and overall healthcare costs. Medical non-compliance is occurring at epidemic proportions for countless reasons. Patients may need to purchase food instead of hypertensive medication, or they may disregard the follow-up test because they are unable to take the time off from work, or simply because they cannot find transportation to and from the hospital. Can treatment non-compliance be concerning enough to consider the consequences as a catastrophic issue? Well, does it affect enough of our population in order to be considered an epidemic? According to the World Health Organization, approximately 125,000 people with completely treatable ailments will die each year in the United States because they do not take their medication properly. The same group, the same organization also reports that 10 to 25% of hospital and nursing home admissions result from patient non-compliance. Furthermore, about 50% of prescriptions filled for chronic diseases in developed countries are not taken correctly, and as many as 40% of the patients do not adhere to their treatment regimens. Surveys have confirmed that despite our best efforts, patients leave medical offices understanding less than 50% of what they were told. This lack of understanding leads to non-adherence that is estimated to cost somewhere between 100 and 300 billions each year. Nursing plays a major role in supporting patients' acceptance and adjustment to the impact of illness on their lives, and adherence from a patient-centered approach supports the goal of nursing by advocating for what is best in the context of each patient's life. This concept presentation will serve as a preliminary step to a broadening nurses' appreciation for the complexity of adherence as a patient behavior and represents an integration on what we know about adherence. Please take a moment and stop this presentation in order to review the goals. Variation and debate exists on how to define adherence, how it differs from compliance or concordance, and how the behavior of adherence relates to patients, healthcare professionals, and the system factors. This slide is giving you the NANDA definition in one from the Christensen. Cohen, in a concept analysis of adherence related to the nursing practice of patients with cardiovascular disease, defined adherence as, and I quote, persistence in the practice and maintenance of desired health behavior and is the result of active participation and agreement, end quote. Compliance and adherence have often been used interchangeably, and as the healthcare community adopts the concept of patient-centeredness and activation, it is moving away from the term compliance, which implies a certain patient passivity in following the prescriber's recommendations. Adherence has a more positive connotation, has a protective implication, may mean a proactive behavior, which results in a lifestyle change by the patient. Adherence refers to a process in which the appropriate treatment is decided after a proper discussion with the patient. Adherence has been used as a replacement for compliance in an effort to place the clinician-patient relationship in its proper perspective. Adherence refers to a process in which the appropriate treatment is decided after a proper discussion with the patient. It also implies that the patient is under no compulsion to accept a particular treatment and is not to be held solely responsible for the occurrence of the non-adherence. Adherence has been defined as the extent to which a person's behavior, taking medication, following a diet, and/or executing lifestyle changes corresponds with agreed recommendation from a healthcare provider. Now, what will be the non-compliance? Well, the non-compliance represents the failure or the refusal to comply. In medicine, the term non-compliance is commonly used in regard to a patient who does not take a prescribed medication or does not follow a prescribed course of a treatment. A person who demonstrates non-compliance is said to be non-compliant. We'll look now into the scope of this concept. The scope of adherence essentially ranges from a total lack of adherence to a complete adherence, and you can see it in this image. The degree of adherence within the range includes the patient's intentional or rationale in the decision to stop the medication or change the dose or the frequency of the medication. May also include any type of unintentional change in the medication taking behavior, which will represent a non-purposeful overlooking of taking the medication. We'll try and answer now a couple of questions regarding the scope and the categories of this concept. And the first one will be, what questions could nurses ask to assess the patient's interest and understanding of the recommendations? A second one will be, what questions could nurses ask to determine the patient's degree of willingness to follow the recommendations? And the last one will be, how can the nurse involve the patients in the decision? So if we are looking at the concept, it represents a multidimensional phenomenon. The adherence is determined by 5 dimensions according to the World Health Organization, and these dimensions are socioeconomic factors, provider-patient or healthcare system factors, condition-related factors, therapy-related factors, and patient-related factors. Poor adherence is the main cause of ineffective treatment, and nurses are very familiar with the frustrations caused by treatment failures, poor health outcomes, and patient dissatisfaction overall that will accompany poor adherence. It is crucial for nurses to assess the patient and foresee any possible cause of non-adherence. The first step to solve the problem is to find out to what degree these dimensions of adherence will affect the patient's behavior. A basic but also very clear cause of non-adherence is the expensive medication regimen. Changes in physical and psychosocial functioning, such as difficulty in handling medication containers, diminished sensory abilities, altered cognitive function, reduced self-confidence, depression, and social isolation can affect a medication behavior. Cultural and individual health beliefs may interfere with the medication self-management. Previous negative experiences with medications, side effects, or ineffective medications may diminish the willingness of a patient to comply with a new regimen. People that have chronic illnesses may have also difficulties in modifying some health behaviors such as exercise and diet and smoking and alcohol ingestion. The patient education plays an important role in achieving the adherence, and it is vital to educate the patients and convince them about the benefits of the regimen. To achieve medication adherence, a patient should be well informed about the chronic disease and the complication associated with the non-adherence. Another important interventions are communication, good quality in patient-nurse relationship, and collaboration of a team of healthcare professionals. Nursing interventions need to be based on innovative approaches that involve patient participation in self-care and continuous assessment and monitoring of treatment regimens. Such strategies reinforce therapeutic partnership between patients and nurses. Nurses can provide the link and support through home visits, phone calls, and other reminders that facilitate adherence. Side effects of medication and their impact on patients' quality of life must be mentioned and detected by nurses. Nurses must respect the beliefs and choices of the patient and must assess the degree of adherence, avoiding judging the patient. Tailoring the therapy to the patient's needs is sometimes necessary, and this includes investigating patients' preferences, simplifying dosing regimens, and using adherence aids. Since the patient's adherent behavior is based on his or her view of trusted and knowledgeable nurses, it is important that nurses remain trustworthy and knowledgeable. So, how will nursing students in the class will ensure they are trustworthy and knowledgeable? Please take a moment and think about those notions on your own and make a few notes. We continue looking into the scope and the categories, and we see that the consequences of non-adherence will fall into 3 main areas. The first one will be the patient-related one. The second one will be the health professional-related one, and The third one will be related to the system, to the healthcare system. The patient-related consequences will include increased mortality and morbidity, conflict, attributional uncertainty, embarrassment, and definitely changes in quality of life. Health professional-related consequences will include uh, ambivalence, misinterpretation, avoidance, decisional conflict, and empathy. Those related to the system will include an increased cost and in healthcare service use and an increase in the usage of services, and as a result of that increase in cost. Nurses are present in the majority of healthcare settings in which the patients will receive treatment recommendation, and this provides an excellent opportunity to assess motivation and integrate as well as reinforce treatment adherence strategies for our patients. We'll describe now and we'll look into the theoretical links for this concept. And in order to do that, we will try to explain why intentionality is a key component in the theoretical links and the factors that will influence the intentions. The theory of planned behavior is a theory used to understand and predict behaviors. In this theory, we say that behaviors are immediately determined by behavioral intention and, under certain circumstances, perceived behavioral control. So behavioral intentions are determined by a combination of three factors. We have the attitude toward the behavior, the subjective norms, and the perceived behavioral control. The theory of planned behavior is built out of a number of constructs, and the first one will be the attitude towards the act or the behavior. In other words, an individual's belief of whether a certain behavior or act makes a positive or a negative contribution to the person's life, to the owner's life. The second construct is called the subjective norm, and this one focuses on everything around the individual. In other words, it will be made out of his or her social network and the cultural norms and the group beliefs and everything that makes out for the society and the environment of that individual. The third construct is called the perceived behavioral control, and this one refers to a person's belief of how easy or how hard it is to display a certain behavior or act in a certain way. We can use the theory to predict that if a person has a positive attitude toward an act or a behavior, and they are surrounded by several social norms, and they have a high level of perceived behavioral control, all of those will be the best predictors for forming a behavioral intention, and in turn, they will lead to the person actually displaying the behavior or act. Another theoretical link is based on the health belief model, and this model is a tool that the scientists are using to try and predict health behaviors. Originally developed in the 50s and updated in the 80s, this model is based on the theory that the person's willingness to change their health behavior is primarily a result of the following factors. One will be the perceived susceptibility. In other words, people do not change their health behavior unless they believe that they are at a risk. For example, those who does not think that they are at a risk for acquiring HIV from unprotected intercourse are unlikely to use a condom. Young people who don't think they are at risk of lung cancer are unlikely to stop smoking. A second one will be the perceived severity. The probability that the person will change his or her behavior to avoid a consequence depends on how serious he or she considers the consequence to be. For example, you're young and in love, and you are unlikely to avoid kissing your sweetheart on the mouth just because he has the sniffles and you might get his cold. On the other hand, you probably would stop kissing if it might give you Ebola. Similarly, people are less likely to consider condoms when they think STDs because they may be perceived as a minor inconvenience. However, when we are talking about an AIDS epidemic, the perceived risk was completely looked in a completely different way. The third element will be the perceived benefits. It is difficult to convince people to change a behavior if there isn't something in it for them. You need to buy them in. And people don't want to give up something they enjoy if they don't also get something in return. Let's give an example. Your father probably won't stop smoking if he doesn't think that doing so will improve his life in some way. Or a couple might not choose to practice safe sex if they don't see how it could make their sex life better. We are moving now into what is called perceived barriers. One of the major reasons people don't change their health behaviors is that they think that doing so is going to be hard. Sometimes it's not just a matter of physical difficulty, but social difficulty as well. Changing your health behaviors can cost effort, money, and time. For example, if everyone from your office is going out drinking on a Friday, it's very difficult to cut down on your alcohol intake because you're trying to be with your crowd. If you think that condoms are a sign of distrust in a relationship, you may be hesitant to bring them up. One of the best things about the health belief model is how realistically it frames people's behavior. It's recognizing the fact that sometimes wanting to change a health behavior, it's not enough to actually make someone to do it. And therefore, it incorporates two more elements into its estimation about what it actually takes to get an individual to make the leap. And those two elements are cues to action and self-efficacy. So cues to actions are external events that prompt a desire to make a health change. They can be anything from blood pressure, um, a van being present at a health fair, by seeing a condom poster on the train, to having a relative even dying of cancer. A cue to action is something that helps move someone from wanting to make health changes to actually really making that change. In my mind, however, the most interesting part of the health belief model is the concept of self-efficacy. And this element, which wasn't added to the model until late 80s, it looks at the person's belief in his or her ability to make a health-related change. It may seem trivial, but faith in your ability to do something has an enormous impact on your actual ability to do it. Thinking that you will fail will almost make certain that you do. In fact, in recent years, self-efficacy has been found to be one of the most important factors in an individual's ability to successfully negotiate the condom use. Please take a look at this. Take a moment out of this presentation and look at this pictureless image, and try to see how in everything that we discussed so far, how it fits into the big picture of adherence to treatments. We'll move forward now and we'll apply the concept to the context of nursing and healthcare. In other words, how can we as nurses encourage the health promotion behaviors? The World Health Organization defines health promotion as a process of enabling people to increase their control over and to improve their health. And that definition was, this concept was introduced in the late 80s. To facilitate that process, we must provide people with appropriate information, and nurses have a key role in providing that information in the form of health teaching. Nurses are highly educated, experienced health professionals, and they are also accessible through many settings. Health promotion by nurses can lead to many positive health outcomes, including adherence and quality of life, and patients increase patient knowledge of their illness and self-management. Take a minute and think about the concept and see what is the correlation between cost and adherence in terms of medication management. You will need to consider therapeutic effects versus undesired side effects, cost, and what are the required changes in the daily activities of a patient in order to adapt to a new medication. We'll continue discussing the context to nursing and healthcare by looking into what will be some reasons the patients have, especially those with chronic conditions, that will make them prone to have non-adherent behaviors. Um, I will give you a paragraph from Chisano, Why are so many patients non-compliant? That was published in Medscape Multispecialty in 2014. And it says, patients don't take their medication for a multitude of reasons, and many of them emanating from the murky depth of human psychology, in which the patients, not to mention medical researchers, may not fully understand. In other words, chronic condition or chronic illnesses are conditions that require compliance and the very strict one to treatment in order for that condition to be under control. When a chronic illness is inadequately managed, the condition may worsen. Chronic illnesses are the first significant cause of mortality in the world, accounting for 60% of all deaths worldwide. In developed countries, approximately 50% of the patients with chronic illnesses may actually follow the treatment. Patient-based causes of non-compliance will include forgetfulness, cost and inability to get the prescription filled, picked up or delivered. Forgetfulness will cause about a quarter of non-compliance cases. And this becomes more of a problem with older patients and patients with cognitive disabilities. And this actually contrasts with the patients who would remember to take medication but cannot obtain it in the first place because they lack of resources and support systems to pay for it or to collect their medication even. High costs account for 17%, almost 1 in 5 of non-compliance cases, and inability to obtain filled prescription accounts for 10%. The physician-based causes for non-compliance are those in which the issue starts with the physician. This can be due to a poor doctor-patient relationship or lack of communication. For example, the physician who do not know their patients in a good way will not know which issues are more likely to affect their compliance. Additionally, doctors need to take the time to explain the importance of the medication and how to use it. 70% of more than 1,000 non-compliant patients said that they would be more compliant if they knew more about their illness or condition and how the prescribed medication will help. When we are looking at the medication-based non-compliance cases, those are caused by the medication itself. We have adverse events that may be caused by the medication that can be sometimes very uncomfortable and sometimes even more uncomfortable than the actual disease symptoms. The perceived side effects cause 20%, 1 in 5, of medication non-compliance cases. And complicated regimens may also lead to patient non-compliance. We'll discuss a little bit about, just look at this picture and try and understand how those concepts are interrelated. So we have several concepts that have a converged influence to the degree of the adherence. And those with greatest influence are presented in here. We need to understand how each of those concepts influence the non-adherence and how they become a critical part of understanding why the problem occurs and how patients become at risk because of the non-adherence. Socio-demographic characteristics such as culture and spirituality and stage of development all have been shown to have a variety in various degrees an influence on adherence. For example, younger patients have consistently demonstrated poor adherence to prescribed treatment, with adherence again declining in patients older than 65, particularly those that have impaired cognition and those with limited functional ability. Similar results have suggested that those with less than 12 years of education and lower household income will demonstrate poorer rates of adherence. The quality of family dynamics and perceived family support also will play a role in patient adherence, particularly among those with chronic conditions. Please stop the presentation and take a moment looking over the exemplars of the adherence behavior and try and answer the following questions. Which type of short-term medication are more closely linked to non-adherence and why? Which type of long-term medication are more closely linked to non-adherence and why? What are some barriers to adherence with prescribed diets for diabetic, low cholesterol, renal, or sodium restriction? And what are some barriers to adherence with preventive health activities? What is the term that suggests patients and healthcare professionals come to a mutually agreed upon regimen through a process of negotiation and shared decision making? 1. Persistence. 2. Compliance. 3. Adherence. Or 4. Concordance. Correct answer is 4. Concordance. Concordance is the most recent conceptual term added in an attempt to more accurately reflect the behavior of adherence. It suggests that patients and healthcare professionals come to a mutually agreed upon regimen through a process of negotiation and shared decision making. Which theory first conceptualized beliefs as predictors of preventive health behavior to help explain the failure of some individuals to use these behaviors? 1. Health belief model. 2. Theory of planned behavior. 3. Adherence and compliance model. Or 4. Therapeutic behavior theory. Correct answer is number 1. Health belief model. The health belief model first conceptualized beliefs as predictors of preventive health behaviors to help explain the failure of some individuals to use these behaviors. Non-adherence rates for chronic disease management and lifestyle changes are estimated to be 1. 10 to 30%, 2. 30 to 50%, 3. 50 to 80%, 4. 80 to 100%. Correct answer is number 3, 50 to 80%. Non-adherence rates are estimated between 50 and 80% for chronic disease management and lifestyle changes.